I think we'll get started. Thank you for joining us for discussions and diagnosis. I know our cadence has been a little bit less frequent recently, but it's my pleasure to welcome Ava Liberman from Cornell School of Medicine in New York. And Ava, for those who may remember the early days of CITM, was the first CITM fellow. First of all, she is a neurologist and also has additional training in vascular neurology. And her primary interest is in improving diagnosis of stroke, which of course is an enormous problem, which we'll get to in a moment. So thank you, Ava, for doing this, and welcome to Discussions in Diagnosis.
Yeah, thank you so much for having me. Excited to be here.
Great. So I wanted to start with kind of an overview of the scope of the problem of stroke, the impact that it has on Americans overall.
Oh, yeah. So stroke is, despite improving treatments in the past 10, 20 years, stroke remains a top cause of morbidity and mortality in the United States and elsewhere. And most recently was ranked the fourth cause of morbidity in the United States. So it's a major problem that we have to face.
Okay, thank you. So your focus is upon diagnosis of stroke. How are we doing?
Well, there are kind of two flavors of stroke misdiagnosis. There's overdiagnosis of stroke, which I think actually is an underrecognized problem, and then there's underdiagnosis of stroke or misstroke. So, the key points for stroke diagnosis, most of the work's been done in the emergency setting, just kind of given the availability of acute stroke treatments that are time sensitive. So a lot of work has been in the ED. And in terms of overdiagnosis of stroke, it probably occurs in about 8% of patients who are labeled as having a stroke in the emergency department. So, a non-trivial amount. And then missed or delayed stroke diagnosis, so that is failure to recognize a stroke when someone has it, occurs in about 9% of patients in a large meta-analysis in 2017. So I think it is, 10% is kind of a good number to keep in your mind about stroke misdiagnosis, but keeping those two flavors in mind are important because, there can be both harm from stroke misdiagnosis, failure to give acute treatment, failure to initiate secondary stroke prevention strategies, but then, overdiagnosis, which has kind of been understudied, has other problem, unnecessary treatment, delayed diagnosis of the true condition like seizure or migraine or functional neurological disorder. So those are kind of two flavors of stroke misdiagnosis.
So in a scenario where someone comes in, maybe they have some rather vague symptoms and stroke is not diagnosed when a stroke actually takes place, what are the general outcomes that you'll see? Let's say they come into the emergency room, and do we know much about what happens to people?
Yeah, I mean, so I can talk about the symptoms that are often missed before, but just to your question of kind of like, does it matter? There's a really nice actually study from Switzerland where they had a registry of stroke patients and they looked at patients who had a delayed diagnosis in the ED and then were subsequently during their admission not found to have a stroke and got sent home, and then subsequently were found to have a stroke in the outpatient setting. And they actually had increased mortality at 12 months. So there is and failure to initiate secondary stroke prevention, poor blood pressure control. So all the things that we do to prevent a subsequent stroke, if you don't make that initial diagnosis of stroke, then you don't initiate secondary stroke prevention, you're still just on primary stroke prevention. So I think that's probably the biggest problem with stroke misdiagnosis is failure of secondary stroke prevention, both medical management, looking at someone's carotids to see if they have stenosis, AFib detection, all those things we do. If the stroke diagnosis isn't made, that's not going to happen. And then there is a small percentage of patients who are precluded from thrombolysis or other interventions in the acute setting. But that's probably a smaller number, on the order of 1 to 2% because of just sort of delays in stroke presentation more generally. I think the harm really is in the failure to initiate targeted secondary stroke prevention and eliciting stroke mechanism. That makes sense.
Yeah, that's really helpful. So before we get to symptoms, how would we know those people have had a stroke? Let's say stroke is not diagnosed, and how long does that take usually for us to figure out?
It depends a little bit on the syndrome and what exactly the degree, I would say, of deficit. So transient and minor symptoms, and they kind of get better, right? So it's hard to know unless you get neuroimaging, advanced neuroimaging, or they have another stroke. And then you're like, oh yeah, that was, we missed that. And then patients with more severe symptoms, that typically those patients are hospitalized. So we find out they've had a stroke, during that index hospitalization. So like in a patient who comes in obtunded, for instance, and they're initially, in the ICU, turns out eventually they had a basilar thrombosis, and it took a while to figure that out. Those patients are typically diagnosed within, days,
Mhm.
but those are very sick. So there's kind of two spectrum of stroke misdiagnosis or delayed diagnosis. The, really sick patients who are hospitalized, and we try to figure out what's wrong with them, and then patients with minor or transient symptoms who are often sent home. And you know, the time to diagnosis is different in those two cohorts. Obviously, some are, still under medical supervision, and others are home. Does that make
Great.
sense?
Yeah, certainly does. So based on that, and I know we're going to talk about the clinical features to watch for, but
Yeah.
what do you think are the primary drivers of misdiagnosis of stroke?
Yeah, it's a good question. I think, yeah, and there's been a lot of some of my work and other work, specifically focused on the emergency setting. I mean, when I think about it, to me, a key kind of point is the emergency medical setting is an extremely challenging one within which to make a rapid diagnosis. So I think there are a lot of environmental factors.
Mhm.
I think another thing that's worth mentioning, and I think is really important, is that I did a study using a nationally representative survey called NHAMCS of EDs nationally, and I looked at just how many people come in with neurological complaints to the emergency department, forgetting what their diagnosis is, whatever. Um, and it's about 14 million visits in the U.S. per year. So it's a huge number of patients who have some neurological complaint, and I think, figuring out who has a dangerous condition, who has a benign condition, with that volume of patients is extremely challenging, because you can't work up everyone for a stroke, right?
Mhm.
That's just
Mhm.
insane. So I think that's a challenge, is sort of distinguishing who has a vascular condition, who doesn't. And then I think, another challenge in neurology is I think there's a lot of discomfort with the neurological exam and neurological diseases in general. And when there's poor access to consultation, or, some amount of neurophobia, it leads to kind of strange diagnostic decision making. And I think that's a problem that's been recognized, nationally, and probably starts at the residency or even medical school level. This sort of neurophobia,
Oh, yeah.
neurology is so complicated we can't possibly understand it. And I think that bias is a source of diagnostic error as well. And I've done some interviews and qualitative work to support that claim.
Okay.
Um, and then what else? And then I think, one other thing that's come up in a study I did using sort of like this engineering methodology to understand process breakdowns, is that if the patient isn't thought to have a stroke that's intervenable, that is to say, they're not a thrombolysis
Mhm.
candidate, they're not a thrombectomy candidate, the thinking in some ways kind of stops. And I think sometimes the emphasis on, acute stroke treatment can kind of blind us to other types of strokes that are also harmful. And so
Right.
I think that's one of the other kind of
The
challenges
drive.
in stroke, is that there's a lot of attention up front. There's a stroke code, everyone, goes
Yeah.
crazy. But then afterwards, the picking up the pieces part, I think, can be a challenge. So I think that's another source of not so much diagnostic inaccuracy, but definitely management and treatment issues.
Okay.
I could go on, but those are, I think, the top four.
Yeah, that's really helpful, Ava. So I'm wondering, like, talking about symptoms, I mean, the classic education that we get in medical school or in residency is, slurred speech, weakness on one side, unsteadiness of gait. And if I see that, oh, I think this person has had a stroke, and if it's relatively acute, I'll call the team that's involved, and hopefully they'll initiate thrombolysis or some other acute therapy. But what should we be watching for in addition to those classic symptoms?
Yeah, I mean, I think they're the typical symptoms of stroke, and then the atypical ones.
Yeah.
As you alluded to, the typical ones are, weakness on one side, with facial involvement, aphasia, neglect, so things that are kind of easy to see. Dysarthria is actually like tough, right? Because
Mhm.
it's so nonspecific.
Yeah.
But certainly dysarthria in the context of other neurological deficits is one. I think thinking about vascular syndromes can be really important. If the patient is complaining both of, diplopia and they have some facial weakness, you have to kind of think about the brainstem. So I think trying to think not just kind of a screening neurological exam, let's see what the deficits are and add them up and come up with some, their left arm is weak and their right ear doesn't work. But thinking really, what's new, what's old, and what kind of could actually localize somewhere. So I think that's a helpful way, and that's challenging, right, for non-neurologists. But I think thinking about, what are their prior deficits, what are their new deficits, how do they match up? Because a lot of times people with old strokes or prior neurological injury, those are ones that are missed, often.
Yeah.
So I think that, old versus new is a really important distinction. And then, could this be a vascular syndrome? Could it not be? And then for each, there's some tricky ones, right? Dizziness is tricky. I think altered mental status is tricky. Headache can be tricky as well. Those are kind of the three that are really challenging. Then mild or minor transient symptoms is another group. So those four buckets are, I think, real sources of error. And in those groups, I said diagnostic stroke misdiagnosis is about 10% kind of globally. In those groups, minor stroke symptoms, minor transient stroke symptoms, dizziness, altered mental status, and headache, it's probably on the order of 40% or so.
Oh, wow.
So
Okay.
those symptoms, and they're challenging, right? Clinically, they're
Yeah.
challenging.
Well,
What's a
headache is very
dangerous
challenging.
headache? What's not
Yeah.
a dangerous headache? Can be very difficult to tell, particularly if there's a history of headache, in the past. So I think, just practically speaking, think about the vascular syndrome. Like, does it add up? Don't just do a screening neuro exam, but like really try to narrow in on that. And then distinguishing old from new, I think, are two very helpful things.
Yeah, so the old from new is really interesting. Well, let me give you
Yeah.
kind of a scenario. Let's say it's a couple that comes in, and the husband is the one who's affected. He's in his late 70s.
Okay.
His wife was also in her late 70s. And she said, well, he was reluctant to come to the emergency room, but he's not himself. He seems a little bit confused. But, I do that screening neurological exam as a primary care doc, or if I'm an ED doc, I don't find any focal deficits per se. What would be your approach in that case? Let's say, let's say he doesn't have, he has some cardiovascular risks. He's got some other chronic diseases which have been stable, but he has no history of stroke.
Yeah, I think I would really zero in on my exam on the language exam. I
Okay.
really try to get a sense of, is there any language dysfunction? Is this confusion actually an aphasia? That is to say, is his speech or his comprehension of speech disrupted? And that's why he's confused. And I would look very closely and ask myself, is there any facial asymmetry? Because if you've got some language dysfunction, you typically will have a facial droop, typically on
Yeah.
the right side, if it's left hemisphere. So that's what I would do. And then I would sort of think, is there anything else, right? Like, does he have a UTI? Does he have,
Yeah.
pneumonia? Like, because common things are common. And so I would not jump to an MRI in a patient like this. I would
Okay.
really sort of think, is there anything, that neurologically could explain, and is it transient global amnesia, right? Is he asking repetitive questions? Is it something else, to get a seizure history potentially? But I would sort of think, if my language exam is really good and there's really nothing there, and there's nothing concerning for, repetitive questioning, and he's not waking up, having urinated on himself with a tongue bite, I would probably pursue a medical workup in that case.
Okay. Okay. That's really interesting.
Yeah.
So,
I think, the idea of MRI in all these kind of patients is not, I
efficient.
think it's low yield.
Yeah. You mentioned initially, and then we hadn't initially talked about, discussing this, but the issue of overdiagnosis. So,
Yeah.
I can see, I used to be an ER doc many, many years ago,
Okay.
and I can see, okay, I've seen a patient with a stroke. I missed the diagnosis. I discharged the patient. They wound up having a diagnosis of stroke. Somebody is upset about this. And I can tell you, every patient that comes in with confusion or delirium or some deficits in language, I am thinking stroke right away. But what are some of the drivers of overdiagnosis that you're aware of?
Yeah. Overdiagnosis, I think, often is, the most data on it is overdiagnosis leading to thrombolysis. So a patient comes in within a time window of 4.5, 6 hours, whatever the time window is, depending on the time the study was done. And there's sort of a rush to treatment. So I think rushing to treatment is a key issue in administration of thrombolytics to what are called stroke mimics, so patients who
Mhm.
are thought to have a stroke but do not. Um, and so I think it really is this emphasis on speed in acute stroke that leads people to just kind of make decisions quickly. And typically these are patients with what seem like usual neurological symptoms, right?
Right.
They're plegic on one side, they're aphasic, and they don't have a stroke, they have a seizure or a migraine or a functional neurological disorder or an old stroke, and they've got some recrudescence. So those are kind of the things. I think it's a sort of quickness, the emphasis on speed leading to thrombolysis. And it's largely safe. The administration of thrombolytics to stroke patients, if you TPA is a little worse than TNK, but just using the TPA numbers, TNK is maybe 1% less.
Mhm.
TPA is the bleeding risk in national studies is
Yep.
about 6% for patients with stroke. In stroke mimics, it's like on the order of 1%, right? So the
Oh,
the
wow.
the
Okay.
risk of thrombolysis to a stroke mimic is low. But I think what happens to these patients, one, there's a lot of cost, and two, whatever is really going on with them remains unknown, right? So
Mhm,
they come
mhm.
back, they don't get treated for their seizure. So I think those are some real harms in that population. And you don't want to give a medicine to someone that they don't need that's
And
got
it's
some
traumatic to
risks.
be for the patient and the family to know that, "Oh, you've had a stroke, we've gotta act right."
Right.
Right? That can't be
Yeah.
very pleasant for sure.
Yes, there's a
Yeah.
lot. There's actually a
Mm.
really nice British study that came out recently looking at the psychological harm of being told you've had a stroke or TIA, both for the
Uh-huh.
patient, for the family, and then actually some like insurance related issues like that.
Okay.
Like the rates go up and stuff. So yeah, no, I think that's another important area, and I think in that context, diagnostic pause can be really helpful when you're rushing and you're thinking like, and this would be something in the emergency setting
Mhm.
but you're rushing and you're trying to get the thrombolysis and you're trying to do everything, pausing and saying like, could this be anything else briefly, not causing a
Mhm.
delay, I think can be really helpful.
Now, are we on the same order of magnitude? I mean, time is myocardium. Obviously, if somebody's had a myocardial ischemia or infarction, is that a similar situation with
Yeah.
thrombolysis as well? So we've got we
Time
have
is brain.
time is brain. So okay,
Yeah.
all right. So that's why the
Yeah. And
protocol
and the
is so
rushing I think makes sense. And I think
yeah.
sometimes, there's kind of this interesting balance that was first articulated by Jeff Saver when
Mhm.
I was like probably in middle school, balancing swift and sure, right? You want to be fast in acute stroke treatment. And sometimes you want to be sure, but if you jeopardize, if you try to get diagnostic certainty at the cost of swiftness, you'll end up
Mhm.
causing someone to have a much worse stroke. So it is a balancing act, and I think it is a challenge. But I think knowing in each case when to be swift and sure is part of the problem.
Right. Yeah.
Yeah,
A huge challenge. So I guess the big question, and we have a couple minutes, and I want to throw it open to questions to the group. Is what do we do to fix the problem of misdiagnosis? From I mean, it can be anything, Ava. It can be the system level, it can be
yeah.
education. What are your thoughts about that?
Yeah, I think focusing really on these symptom-specific issues and providing some clinical decision support could be really helpful. So
Hmm.
for dizziness, there are the GRACE 3 guidelines which came out.
Yeah.
Knowing what the heck those are and how to actually implement them, I
Mhm.
think is fairly challenging. I mean, I like to say I'm a visitor in the ER. I come and then I leave, and I see a very small section, but I think some clinical decision support around dizzy, headache, altered mental status, just to give people some sort of algorithm and rubric. When do we need an MRI? When is a CT not enough? I think would be extremely helpful because I think that it's just hard to keep up with that sort of thing. And then I think some triggers and real-time flags in the emergency setting could be helpful. So one thing we mentioned earlier, I'm working on looking at people who come in with severe hypertension, which
Mhm.
can be a marker of acute stroke. Right, you have a stroke, your blood pressure
Yeah.
goes up. That's sort of a known thing. But then there are lots of people with uncontrolled blood pressure just walking
Of
around.
course. Yeah.
And so thinking about, how can we help emergency providers who, see millions of patients with uncontrolled, with severely elevated blood pressure, targeting who needs advanced imaging or a neurological exam in that group. So I think and maybe it's prior risk factors, maybe it's prior stroke, maybe it's some features of what the patient says. So I think some flagging of patients in real time can also be really helpful to kind of help sort out the needle from the haystack in a way for patients who have neurological symptoms that are related to
Mhm.
cerebrovascular disease.
And
So
would you, when you say clinical decision support, I mean, we've got the guidelines on the back end, but this would be
yeah.
something that would say, hey, would you consider stroke in this particular patient?
Yeah, exactly, like
Okay,
an
right.
EMR kind of fix,
That's
or,
great. Yeah.
hey, this patient, and I think this could actually be true for dual antiplatelet therapy, but, hey,
Mhm.
like, you got a head CT on this patient, you thought maybe they were, their dizziness doesn't make sense to you, like, have you considered Hint's test, or have you considered, and
Mhm.
some sort of, kind of ways to help people think about next step decision making,
Mhm.
to provide support, and I think to partially get away from this neurophobia phenomenon, where people feel like, oh, it's just a mess, to kind of give some rubric to go with. And it may be imperfect, but I think
Right.
thinking about that in a symptom specific fashion for these atypical cases, I think is really helpful.
That's fantastic. Thank you for that
Yeah.
insight. Now, as a generalist who probably has neurophobia as well, and it's like, oh, I've got shooting pain down my leg, oh gosh, or whatever it is, my
Right. You're like, oh, I'm gonna have to like think about
I don't know.
sciatica.
Maybe
Yeah.
they've got MS and that's what
Right.
they're
Right.
worried about, and you go down
Yeah.
that road. But I'm just wondering, some of those clinical skills that you mentioned, looking for facial asymmetry, do you think that we could do a better job in because I mean I would do the screening neurological exam looking for weakness, reflexes, speech, and gait, and I'm done. 2 minutes, okay, and then I start to think about decision making. But should we incorporate more than that into how we evaluate patients on a routine basis?
Yeah, I mean, this is a bit of my own soapbox, but I'll just to take a step back. I think a problem with the way we teach neurology is we teach this screening exam, whereas in every other area of medicine, we teach hypothesis generated exam,
Mhm,
right? So, like, if a patient comes in with a headache, let's say,
mhm,
like their reflexes kind of don't matter, right? Like, and
mhm,
so I think, I would focus like on a fundoscopic exam for a patient like that. Whereas if someone comes in with arm weakness, then maybe
mhm.
their reflexes matter, facial droop really matters to decide where the lesion is. So I think we just need to start teaching a hypothesis generated exam, because I actually think in watching learners and even non even some neurologists, frankly, you do the screening exam and then it's just kind of a mess, right?
Yeah.
They're weak in their leg, their arm is kind of funny, their hand taps, and it's
Mhm.
just who knows. So I think going into a neuro exam with a hypothesis, and there's some data to support this, though not a lot, can really help think about um, uh, not getting better at the exam. I think medicine docs are good at the exam, but thinking about what parts of the exam are most salient and what am I looking for, and focusing on that. Because I think it's just hard to synthesize different parts of the neuro exam, because it has to match the complaint that the patient has. Does that make
Right.
sense?
Yeah, it does. Yeah, and I think a lot of our residents will come to you. So I did a screening neurological exam, which was normal or abnormal, and you're right.
Right.
It just pushes you in directions that are hard to integrate with the overall picture, I think
Yeah.
is what you're saying. Okay.
And if I were to design a medical school curriculum, I would say, okay, the patient comes in with dizziness. What
Mhm.
are the neurological, examination maneuvers, bedside testing that are most essential? And then you can
Mhm.
look, make sure they're not weak, right? But like
Yeah.
cerebellar testing, walking, right? You could sort of think of a list. And a seasoned clinician, I think, could do this. But I think teaching it that way could be really helpful.
Okay, that's fantastic.
Yeah.
We're going to throw it open to some
Okay.
questions here, and Dr. Marsh actually had typed a question in the chat, and I think it's something everybody is wondering about, and of course, the use
AI.
of AI, and of course, it's getting a lot of attention lately. But if you have any thoughts about that, please share
Yeah.
them.
I I don't know. I'm not like a what's the good term? I'm a Luddite. I'm
Mm,
not like up to speed on AI,
mm,
but I think there has been some work. I think really interesting work using natural language processing, but it could be AI too, for patients who are being brought somewhere by EMS, and so
mhm,
looking at the EMS record, you could imagine AI. This was some data on NLP. Thinking about based on what EMS says, does the patient have a stroke or not, which can really affect routing of the patient. So like I imagine this is true in Ohio, but I don't know. But something in the, I think early on, pre kind of diagnostic space, AI or could really help kind of think about where the patient should go and what's their risk for stroke in the acute setting. So I think that's really useful. I'm hesitant to put that much trust in AI for diagnosis of stroke, because it's so variable, depending on what part of the brain is affected. I think it could be kind of hard to do that, but I think in the pre-hospital space, trying to figure out what the risk of this person is for having a stroke right now could be very useful.
Mhm.
And there's some data to support that, but um, I defer. I'm sure there's someone smarter than me who knows more about this that could
Yeah,
speak to that.
it's hard, and I'm not I guess I'm kind of a Luddite. It's hard for me to imagine how it would be helpful. I mean, risk factors are pretty well known. We have machine learning that can steer us to what kinds of patients are being missed in our particular setting. And you mentioned the use of AI for steering patients to the right facility, but
Yeah.
what is it? What's the input that would help us improve diagnosis of stroke is hard to figure out right
Yeah, I mean, I think it is neuro exam and like sort of symptom specific, listening to what the patient
now.
says in a certain way. You can imagine AI. I mean, I guess you can imagine some AI vision maybe, and there is
Mhm.
this like, there's some interest in like looking at patients with telemedicine and thinking about, how do they move, where do they move, could that help us with stroke? And then there's some like wearable technology too that could,
Yeah.
if all of a sudden the arm stops moving, there's an alert.
Mhm.
So I think that to me the pre-hospital space is one that could be helpful, but I agree. I'm not sure what additional data aside from an exam could be helpful.
Okay.
But
Well, thank you, Ava. I'm going to open it up again. Any additional questions for Dr. Lieberman? Everybody's very quiet this morning. Okay, if there's nothing else, I want to thank Ava for joining us this morning. Wonderful talk. Oh, Mary, sorry, did you have a question? Please go ahead.
Just quickly, I was curious about the engineering approach that you took to your inquiry.
yeah, we did a failure mode effects and criticality analysis at three different centers, three different comprehensive stroke centers in Chicago. Each had primary stroke centers, and we basically tried to get at how ED patients come in and are assessed for stroke, and what the high risk failures are, and potential mitigating strategies. So the highest there are a bunch of different things, but what I found most kind of relevant and interesting is that the key kind of diagnostic moves in stroke patients in the emergency setting happen really early on. So if you fail to suspect stroke kind of early on in the process, there are a whole bunch of bad downstream effects. There's not a good catch-up mechanism. And so thinking about ways to kind of have a check at the end of an evaluation, what do we think at the end of the day? What did this person come in with? I think can be helpful because the highest risk kind of portions of things are really upfront. And then, obviously improving screening tools but I think a check can be really beneficial. So we just use an FMECA methodology, failure mode effect and criticality analysis. And it was a really cool project actually. I learned a lot from it.
That's awesome, Ava.
Yeah. And
Well,
it's published. It's published in it's my American, I think AEM, Academic Emergency Medicine.
emergency medicine. Okay,
Yeah.
great. Thanks for that referral.
Yeah.
And thank you for joining us. Wonderful, fascinating discussion. I'm seeing patients this morning, so stroke's going to be top of mind anyway. Most of them
The
are
one
older
other thing I
folks.
wanted to say, I think there is some like what's the word? Not nihilism about, stroke patients like, they're on aspirin, they've got hypertension, or what
Yeah,
does it
what else
matter?
can I do? Yeah.
What else can I do? And I think, dual antiplatelet therapy for TIA and minor
Mhm.
stroke really is a very powerful treatment for 21 days. And so it's worth in the outpatient setting thinking about that. If the patient's within 72 hours of their, potential TIA minor stroke, thinking about DAPT is important because I think a lot of people are like, well, they're already, we're managing the
Yeah.
risk factors.
Yeah.
But I think that's one kind of newer evidence-based therapy to consider.
Great.
That's my last sheet.
Okay. Wonderful talk, Ava. Thank you for
Thanks so
joining us this
much. All the
morning.
best.
For everyone, this will be on YouTube as well as you, Maddie, within a couple of weeks. Great. Have a wonderful day, everyone. Bye-bye.
Bye.
Thank you.